Let's get started here, everybody. Welcome to SCS 101. So this is a new series that we are doing where we'll talk about general counterstrain concepts and SCS concepts for different parts of the body. Today is our first SCS 101, so this is just going to be a general intro into the technique, its history, what it is, and how it can help you. My name is Kyle Kusunose. I am the administrative director at the Jones Institute and a physical therapist here in San Diego, California. And I'm here with longtime SCS instructors, Randall Kusunose, Larry Ham, and Robert Dowd. So I'll give each of you gentlemen a couple minutes or a minute just to introduce yourself, how long you've been doing counterstrain, what your history is, and where you're practicing now.
Well, I'm Randall Kusunose. I was the longtime director of the Jones Institute for probably 32 years or something like that. But I was happy to step down and let Kyle take over because after running the Jones Institute for that long, definitely it was time for me to step down. And how he was able to change what we did at the Jones Institute because of COVID was nothing short of miraculous. And so he's done a really great job of running the Jones Institute. I've been an instructor of counterstrain for 34 years. So I have a very long history with counterstrain. I've taught probably over 750 courses, and at least 150 of those are international.
Larry?
Larry Ham. I'm a PT and an athlete trainer in Spokane, Washington. I took all the mobilization courses way back. Mobilization teachers said that there was this quote unquote wild and crazy guy doing this unusual stuff, Dr. Jones. And so I decided I had leg pain, sciatica, back pain, couldn't get rid of it. Went to a class, Randy, and Dr. Jones was there. Dr. Jones was kind enough to treat me for 15 minutes after the first day, and all my pain went away. So I figured there must be something to it. So I just kept following him around all over the country and learned and became a TA. And then, I don't know, about 13 years ago, began teaching strain counterstrain 1 and 2. And I teach the visceral course, fascial course. I've been doing that for about 4 years now, I believe. But it's definitely revolutionized. There's no way I would have continued to be a PT unless I would have been introduced to strain counterstrain. I'm convinced of that at my elderly age now.
Thanks, Larry. And Robert?
Hello, everybody. My name is Robert Dowd. I can't believe it, really, but I guess I've been doing this for 32 years. Took my first course, like Larry, I think, with Randy and Dr. Jones and a few other osteopaths back in the day, back when we had a little tiny syllabus that was little yellow covered and just a few pages. And gosh, we just kind of sat around and listened to Larry and Randy talk through the course. Back then, it was kind of like this class. It was the full body. We learned cranial to toes in 3 days, 2.5 days. And then we brought in patients on that third day. And Larry walked us through treating some patients. So I got to say, the way we do it now, the way the Jones Institute is set up now is so much more conducive to really learning. I think I came away my first weekend knowing 3 points: iliacus, the radial head, and the upper pole fifth lumbar. But I just happened to be working in a myofascial pain clinic ran by a bunch of physiatrists, and those were the things they couldn't get fixed. So I walked into the clinic and fixed those things on a whole bunch of patients that very first week. And from then on, I think they wrote counterstrain on every referral that I got. So I would say without counterstrain, my 32 years of working as a PT, Larry, I'm like you. I don't think I could, I wouldn't know how to treat a patient without counterstrain. So I'm really excited to be here tonight. Thank you.
Awesome. Thank you, Robert. So if you're just joining us, this is SCS 101, where we're going to introduce you guys to strain and counterstrain, its history, and then what it can do for you as a practitioner. we'll give each of the panelists here a chance to answer some questions, and then we'll do a Q&A at the end. So if you have questions throughout this live webinar, put them into the chat, either in Facebook or in Zoom here. The other thing that we're going to mention here is our upcoming entry-level course for this curriculum. It is a completely new offering, still with 185 of our SCS techniques, but a different distribution model that we're really excited to get out to you guys. So we have courses coming up in San Diego, Chicago, with our first course in San Diego next month that is actually almost sold out. I think we have one remaining seat available in that course. All attendees here tonight too will have a discount to any of our SCS entry-level complete body courses using the code SCS50 at checkout. And that code is good through the end. So let's get started with this question for Randy. Just kind of get with what is SCS? What is strain and counterstrain?
Well, the definition of strain counterstrain by its developer, Dr. Lawrence Jones, was that it was an osteopathic manual medicine technique. So origin is in the osteopathic profession. It's a manual medicine technique for the treatment of somatic dysfunction. Okay, we are going to, excuse me. This technique involves a passive positional procedure which places the body in a position of greatest comfort, thereby relieving pain and dysfunction by reduction and arrest of inappropriate proprioceptor activity that maintains somatic dysfunction. Now, I realize that that is a mouthful, so I'm just going to simplify it for you. Strain counterstrain is a system of treatment that is under the heading of positional release techniques. There are several forms of positional release techniques, but counterstrain is by far the most popular, the most used around the world, and the most effective. Okay. So given the name positional release, what we're going to be doing with counterstrain is we're going to use gentle body positioning to treat the dysfunction. Now, the dysfunction that we treat in counterstrain is caused by hyperactive proprioceptor firing that causes guarding spasms in the muscle and fascial systems. This can cause aberrant joint position, restrictions in joint motion, lack of joint mobility, pain, edema, all the different symptoms that you'll see with somatic dysfunction. So that's the first part. It's gentle positioning is how we're going to do the treatment. In counterstrain, we have a diagnostic tool that we call a tender point. Okay, so tender points have been mapped out over the entire body that indicate very specific muscle and or joint or somatic dysfunctions. Okay, and we're going to use these tender points to make a diagnosis. So just finding a specific point will make a diagnosis for us. And we're also going to use it to monitor the effectiveness of our treatment techniques. So we're effective with the treatment, then this point of tenderness will be gone. For it to be considered a true counterstrain point, it needs to be a minimum of 4 times more tender than normal tissue. So if you were to push on a tender point with maybe just mild pressure, patients will commonly respond with a jump sign or a grimace sign, indicating they've perceived a very sharp pain when the point is palpated. Now, these points that we have cover the entire body. We have over 235 of the Jones points all over the body, from the cranium all the way down to the foot. And location-wise, they're not dissimilar to other systems that use points for diagnosis, like acupuncture or acupressure, shiatsu, ginseng, Chapman's reflex points, Travell's trigger points, reflexology. These are all systems that use points for diagnosis, and our points have some similarity to them in terms of location. But that's basically where the similarity ends. In counterstrain, again, we only use these points to make the diagnosis and to monitor the effectiveness of our treatment technique. Meaning if the technique is effective, this point is no longer tender. But in counterstrain, we do not treat these tender points, okay? Unlike the other systems, their points indicate that is where the dysfunction is, whether it indicates the blockage of the flow of qi through a particular meridian, or it indicates a visceral somatic dysfunction, or it indicates a local muscle dysfunction. Your treatment in those systems are going to be directed at or on that tender point. You're going to needle it, you're going to inject it, you're going to massage it, you're going to laser it, you're going to spray vapocoolants on it and stretch it. So all of those, the point is treated. In counterstrain, the tender point is not treated. We only monitor it and we use it to make the diagnosis. So that is, I think, difficult for first timers to exactly see what counterstrain is all about. I almost need to demonstrate it. But those are the two kind of primary points for the counterstrain treatment, and that is positioning the patient to relieve the dysfunction, and we use tender points for diagnosis.
And you can watch the introduction to the SCS Complete Body course is available for free on YouTube. And I think we can put maybe we can put a link, Heather, to that page in the comments here, so that people can see that to get an idea of general SCS paradigm. And the other thing for you, Randy, is the history. So, Dr. Jones had this serendipitous discovery of the technique, much like Mackenzie did. So if you could tell the participants here that story.
All right. I definitely am the fortunate one that I got to travel with Dr. Jones for 9 years teaching counterstrain. And he mentored me in so many things other than just counterstrain and treating patients. But he mentored me in my financial life, got me investing. He was a world traveler, taught me all about traveling all around the world. So he was a very big influence on my life. But as you know, Dr. Jones, Lawrence Jones, is the developer of the strain counterstrain technique. He's from a small town in Oregon called Ontario, Oregon, which is right on the Oregon-Idaho border, which is a farming community. And he practiced there his entire career. Okay, so as Kyle was saying, counterstrain did have a serendipitous origin. And in 1955, after Dr. Jones had been practicing for 19 years, he was primarily using osteopathic high velocity manipulation techniques. That was his primary way of treating. And he was quite good at it. So one day he had a young man come into his office with what he called Psoasitis. Now, Psoasitis to Dr. Jones was someone with constant pain in the low back and sacroiliac area, okay, is in a kyphotic posture, cannot come up to a fully erect position without extreme lumbar pain. Okay. Now, this patient had been seen previously by 2 chiropractic physicians who applied chiropractic high velocity manipulation to his spine for a period of 6 weeks each with absolutely no relief of symptoms. So when he came in to see Dr. Jones got that history, but he assured the patient that where the chiropractors failed, he would be successful and could help him, because all osteopaths believe that their form of high velocity manipulation is far superior to chiropractic manipulation. Anyway, he applied his own direct thrust techniques to this patient for a period of 6 weeks, and again, with absolutely no relief of symptoms. He said, I did everything I could think to do for this guy, but just nothing worked. He told me there came a point where he started to question the intelligence of the patient, because though he was doing him not a single bit of good, he kept coming back and he hated to see him come through his door. Well, one day he came back and he said to Dr. Jones, you know, I've had this problem a long time now, and it's gotten to the point where I can't sleep at night. Okay. I'm tossing and turning all night long because about every 5 minutes the pain starts again and I have to change position and I'm just not getting any sleep and I'm just at my wit's end. He said, maybe if I could get a good night's sleep, maybe I might feel better. Well, that made some sense to Dr. Jones. And given he wasn't doing him any good with his treatments anyway, he said, yeah, okay, let's see if we can find you a comfortable position to sleep in. So he lays the guy down supine on his table and he starts to move his body parts around. And he's guided by what the patient says hurts or doesn't hurt. So he first flexes the hips up and to the patient, it felt okay. But the further he went, then it got too much and he started to have pain. So he backed off a little bit. Then he rotated him in one direction. That was painful. So he rotated him in the other direction and that felt better. He started to play around with side bending and a lot of different components of the patient's body. And after about 20 minutes of playing with his body, he finds this position where the patient is flexed pretty maximally at the hip. His pelvis is posteriorly rotated. His legs are rotated way off to one side and also side bent to that same side. And the patient feels comfortable. And he says to Dr. Jones, yeah, I think I don't feel any pain right now. This is great. Okay, so Dr. Jones thought that was the only good that anyone had done for this patient for 18 weeks. So he didn't have the heart to take him out of that position. So he pillowed him in that position and he went off and he treated another patient. So 20 minutes later, he comes back and he sees the patient is fast asleep on his treatment table. So he wakes him up and says to the patient, well, how do you feel now? And the patient says, I feel okay. You know, I don't think my back hurts right now. And Dr. Jones says, wow, maybe this will work. Why don't you try getting in this position tonight and let's see if you get a better night's sleep. Well, the patient agrees and Dr. Jones has him slowly sit up. Then he has him slowly stand up and he stands up completely erect and he's free of pain. The patient is ecstatic. He's turning, he's twisting, doc, it doesn't hurt now. And Dr. Jones was pleased, but he said the biggest thing is I was dumbfounded. I just couldn't believe that something as simple as putting him in a position of comfort could get so much better results than all of the treatment that I did on him. He said it was his level of frustration that motivated him to think, well, maybe there's something better out there than what I do or what anyone does. And he started experimenting with all of his patients and putting their dysfunctions into positions of comfort. Now, admittedly, his results were a little sketchy at first, but he was getting good enough results that he persevered and kept on with it. And after about 8 years, he'd had developed quite a few of the techniques in the spine and in the extremities that just worked really well for him. Okay, so this is when he wrote his first article on counterstrain in 1963, entitled Spontaneous Release by Positioning. This was what he called the technique back in those days. This is before he named it strain counterstrain. But this article was published in the Osteopathic Journal. So he got a lot of really good feedback from that article. From there, he kept on developing more and more techniques and finding tender points that correlated with these particular dysfunctions. And in 1972, he wrote his first book on counterstrain, which is when he changed the name to Strain and Counterstrain. And the reason why he named it Strain and Counterstrain was there was the original strain, and he's going to treat it by putting it in a position which applies a counter strain, is how he saw it. So that's what he named it. It's kind of a funny name, but it's been kind of catchy, so it's kind of helped us to popularize the name. So when I met Dr. Jones, though, was in 1986. I got invited to a course called Strain Counter Strain. I had absolutely no idea what it was, but I got invited to it with a whole group of osteopaths. And back in those days, Dr. Jones was only teaching but one counter strain course a year. For decades, he tried to give this technique to the osteopaths, but it was at a time when osteopaths were starting to move away from their manual roots and starting to practice more like allopaths. They liked the technique. They thought it was cool that he did it, but they weren't really interested in learning it. So I took this course, and in this course, I can't say as I came away with a lot of skill, because Dr. Jones's big emphasis was showing people that the technique worked. So he would demonstrate techniques, but then he would do patient demonstrations, okay? Just one patient demonstration after another, showing you this is how it works, okay? So I came away from that class realizing, wow, that really works. I could see that I was working on these patients, but I really had no idea how to do it. So I muddled my way through with the old book and tried the techniques. And, in spite of the fact that I didn't really know what I was doing, I got people better. It was helpful. And so I decided the next year I was going to go back to another class. So in '87, I went back to another class. And again, the only one class he was teaching a year. And he saw me back there, and we went out to lunch, and he expressed to me that the biggest fear in his life is that he would die and counterstrain would die with him, because there wasn't anybody carrying it on. So this is where I tell him that I think I know an audience that might like this technique. And I introduced him to physical therapists, okay? So when I did that, he started mentoring me. He brought me up to a level of counter strain where I was at least competent and could do a little lab assisting at the courses. But once we got me to that level, then in 1988, we started the Jones Institute, and we started putting on courses for physical therapists. And Larry loved physical therapists. He enjoyed their energy. He enjoyed how they loved to lab. He saw them labbing before class. He saw them labbing after class. He would see them labbing during lunch. And that just excited him to see people that were excited about his technique. And he would get letters from them thanking him for developing this technique because it's working so well with my patients. So from there, we started doubling the number of courses we did every year till we were consistently up to 50 to 60 courses in the United States. And then it's also blossomed overseas. We've taught in 7 countries in Europe. We have affiliates in France and Italy that put on a whole series of counterstrain courses with trained instructors. We have the same thing in Australia, and we've been doing quite a few courses in 3 countries in Asia. So the growth of counterstrain has been great in terms of us fulfilling the first goal of starting the Jones Institute, was to have Dr. Jones know that this technique was going to outlive him. He passed away in 1996, but by 1996, he was assured that counterstrain was going to far outlive him. And so he really was a great, great man who's developed this wonderful technique that those of you who haven't tried it, I think you're going to really like it.
Right. And Dr. Jones, his serendipitous discovery was with Psoasitis or low back pain. And that spark really led to the flame where he started playing with positions of spontaneous, eventually finding tender points that correlated to each dysfunction that he was able to assess. And he ended up developing a whole body system, or a complete body system, where he was treating so many different conditions. So as far as what can strain and counterstrain treat, Larry, in your clinical practice, what are the different conditions that you've had success treating with this?
Well, Kyle, you said I had 5 minutes. I started out when I did my outline here. I started with I had 3 hours of information, but I'll cut it down a little bit here. I mean, any type of axial spine condition you can treat with counter strength, cervical, thoracic, lumbar, shoulder, elbow, wrist, hand, any kind of sprain or strain situation. It has been caused by some sort of a quick stretch in a shortened position. Therefore, you just need to identify it. The big pearl here, I think, with this upcoming course in the spine is you're going to find a whole set of points in the anterior aspect of the body, the front of the neck, the front of the thoracic, your anterior pelvis, your anterior lumbars. This is why people can't extend, because they have dysfunction in the anterior aspect of their body. How many people do you know can't look up but have neck pain? How many people do you know that can't get from sit to stand because of back pain? How many people do you know can't static stand because they have back pain? It's because they have anterior dysfunction. You're going to be able to identify those and make changes on Monday after you take this course. You also have posterior dysfunction, but it all comes to scanning and figuring out what is the worst dysfunction, treating it first. But cervical strains, thoracic, shoulder, I took a lot from strain counter strain. I tell my students, you need to fix the tree trunk before you fix the branches. Anybody with hand, elbow, shoulder dysfunction, they have dysfunction in their thoracic spine, the sympathetic nervous system. That's all addressed in these courses. As far as the extremities, I had a patient with patellofemoral syndrome. They couldn't straighten their knee. They had points in the posterior knee. No one had ever gone there before. Almost all practitioners go to where the pain is. We don't go where the pain is. We go where the dysfunction is. Treated her posterior knee. Her knee went straight. Her patellofemoral pain went away. Every time I watch the NFL and there's a high ankle sprain, I just cringe, because the first thing they say, this person's out from 6 to 8 weeks because he has a high ankle sprain. Well, if they would treat the dysfunction of the ankle and the foot right away, I never had any high school football player out more than 2 weeks, because I got rid of their dysfunction. Get them in an environment where they can heal up. We're trying to get people in an environment where they can heal. Obviously, if I've seen a neck patient or back patients that had trouble for months or years, obviously their body isn't in an environment where it can heal. We're trying to do that with counter strain by placing them in a comfortable position. So it works for everything and anything. And if you aren't successful, then maybe there's some underlying pathology going on there. I've had a number of patients that when I was unsuccessful totally, they ended up with cancer or some other more severe entities that wouldn't allow that progress.
Right. And then what's the, Robert, this next question for you, what's the neurophys behind this technique, this slackening or decompressing of tissue? What's happening at kind of the neurovascular level that's allowing us to get these releases?
Well, thank you for asking that. I think as you look around at us instructors that have been around for 30 plus years working with Larry and kind of the old osteopathic concept, we're all board certified orthopedic specialists. And that's kind of what we talk about in these things. But I've always considered myself, even though I'm also an orthopedic specialist, the neuro guy. I work neurology. I work in an assisted living facility. I do home health. I work in memory care units. Many of my patients are in memory care units. So when we talk about the somatic dysfunction that Larry Jones referred to when he was describing somatic dysfunction, the early research on it, and we got a great lecture about this that I gave that I'm sure that we have access to still, but it really is a spinal cord reflex. It's that protective spinal cord reflex that if you get a quick stretch or if you get a pain in a certain position and the body reacts, not on a cortical level, say actively moves out of it, but really that panic, quick stretch reaction to something that surprises you, like you slip on ice or something, you're just walking along and you twist an ankle on a stone or something like that. That the body is set up to protect itself and to go into these protective positions that it will maintain indefinitely. They won't turn themselves off. The body is a great protector of itself. So then the brain, being as plastic as it is, has to adapt and learn how to work on these dysfunctions. So we get a processing error between the central nervous system and the peripheral nervous system. And so what we get to do with counterstrain is we get to come back and we get to put the patient typically in the position that they initially injured themselves in. I can't tell you how many times, Kyle, I've put somebody into a position where before maybe their history couldn't really tell me what was going on with them or why they were suffering in some way. And then once I put them in the position, they're like, oh, you know what? 20 years ago, I fell out of the back end of a pickup truck, and this is exactly how I landed on the ground. And so you're kind of recreating that original dysfunction. But the beauty of counterstrain is we hold them there for that 90-second time in that total positional release position. And then we move them out so slow that the body can't fire in that protective response again. So we're really removing that dysfunction and then allowing and training the brain. Then we get to do all the other stuff that we love to do in physical therapy, all our movement-based and retraining-based techniques and everything, that we get to train the patient again on really how to relearn normal again. We return the body on a spinal cord reflex mechanism back to a state of homeostasis. And that really was the original goal of osteopathy: return it to homeostasis and let it heal. Find normal and let it heal. So Dr. Jones really serendipitously kind of reinforced what the original tenets of osteopathy were.
That homeostasis is going to help facilitate not only optimal function, but healing in all of our chronic pain patients. So without that stasis, your inflamed patients are not going to be set up to heal, right? Great, thank you for that. I'd like to move to really, yes, can benefit the practitioner. So without getting really good results in the clinic, practitioners can experience frustration, a lack of confidence, eventually leading to career burnout. We've all heard about that kind of stuff. But one of the things that SCS really gave me, especially as a new graduate, was this confidence that even though I was inexperienced, even though I had maybe not heard about that patient's diagnosis before, or had never worked with a patient with that diagnosis before, I always felt like I knew her and that I had a good chance of helping that patient because I had proven techniques at getting rid of that patient's pain. Sometimes local, sometimes away from their area of pain complaint. But you guys have taught students from all over the world. Your students told you guys, feedback have they given you about how SCS has changed their careers or impacted their clinical practice? I'll start with, we'll keep our answers a little shorter for the second round, so I'll have all three of you guys answer this one. So maybe just Randy.
Me? To me, counterstrain is really all about palpation. I think with counterstrain, the better palpation skills you have, the better you're going to be at this technique. And those of you that are already very good with your hands, you take a counterstrain class, you'll fly with that. It isn't too hard for you once you have knowledgeable, educated hands. But a lot of therapists feel somewhat palpatorily challenged. And for them, counterstrain is a wonderful technique to start to develop your hands, if that is a goal of yours. Because counterstrain forces you to concentrate on what you're feeling throughout each technique. And if you start to feel those subtle releases, you start to feel the pulsations and the drainage of fluid, you start to feel the drop off in tone, and some of these can be quite subtle. But if you concentrate and you work with it every day, you start to feel those. And I think developing your hands is one of the greatest benefits that counterstrain has to clinicians. Because I can tell you from experience, well, all of you out there, you're all smart. You couldn't be not be smart and get to where you are now. But I can tell you from, again, experience, If you put together what you know up here with great hands that can heal, that can assess, that can pick up small little subtle changes in the body that tells you that something good is going to happen, okay? If you have hands that do that and put that together with what you know in your head, you become a very powerful tool for healing, very powerful. And I think it's one of the best benefits of the counterstrain technique is forcing you to learn how to use your hands.
Great. Larry, you muted.
How we know?
There you go.
I tell the clinicians in my office that we have two modalities in our clinic, our right hand and our left hand. And by using those hands, we can assess dysfunction. Students, I get feedback all the time about how it's impacted therapists' careers because they can now take on patients that are very difficult and have an excellent chance of making positive change. Anybody can make the first 50% of people better by just putting your hand on them and saying you like them. And we're going to do some things for you, whether it's modalities or exercise, whatever. We're trying to get that 85th to 100th percentile patient better. That's where you need counterstrain. And PT clinics all over the country, a lot of them are all doing the same thing. And very few are doing this. And so this can open up a parameter for you, open up a niche for you. I feel very strongly you need to have a niche. I mean, it's just like a business. There's competition in private practice, you know. You need to be able to do something nobody else is doing. Or say, Dr. So-and-so, send me a patient that hasn't been successful at another clinic. I do this technique, give me a shot. And so it's made clinicians more successful financially. It's made them more successful as far as knowing that they can tackle a difficult patient. And we'll talk about some patients here in a bit, but job satisfaction. When I come home from work and a patient tells me that's the first time they've been able to sleep through the night in months, that's very satisfying. Satisfying too if I can get the linebacker to play on Friday night and play well too.
Absolutely. What about you, Robert?
Well, I think what counterstrain has done is it's taken something that could be difficult, like your most difficult patient, say a person with Alzheimer's disease who's on 20 different medications. I can go in and I can work with these patients and I can remove that neuromuscular somatic dysfunction, take them back to a state of homeostasis, and all of a sudden their blood pressures will improve. I mean, we're talking about pain and things. Let's look even at it at a bigger picture. If you are all hunched over, like most of my elderly residents are, it makes it difficult to breathe. You can't expand your lungs. You can't expand. Thanks for coughing there, Larry. You can't expand your lungs. You can't extend that thoracic spine. So by getting in and simply putting them in a position of great comfort. And people may say, well, how can you do that with this memory care patient? Anytime you do something that is the greatest position of comfort for somebody, they typically allow you to do it. And so they like being in that position. And then we don't introduce anything that is hard on them. We bring them out of that position slowly, sit them back up again. It allows you to do things with so many patients, from pediatrics to geriatrics. And I'll be honest, one of the reasons why I initially really gravitated towards counterstrain, it was really easy on me. I was destroying my elbows doing my cross-arm myofascial release on people, doing big, heavy mobilizations on shoulder, standing up. I'm a little short guy, standing up on step stools to try to get that shoulder to mobilize. I could come in there, turn off the subscapularis, turn off the teres major, turn off the pec major, and boom, the shoulder goes up. Something that I thought was a true capsular adhesion was really a neuromuscular protective reflex. Getting in easily, positioning them easily in something that hurts so bad, doing something so gentle to them, gentle on the therapist. They just love it.
Absolutely. What about the patients, right? So as therapists, we've all had to have that conversation with patients at one point in time where we weren't getting them better. Some people have to do it more times than other therapists, right? Where you have to sit them down and say, hey, listen, you're not responding like I thought you would. So I want you to go back to your doctor. I want you to go see this other therapist, right? Who does something, and oftentimes that's counter strainers, right? We get the patients that other therapists in our clinic or in our cities can't get better. But that conversation sucks, right? It as a profession of practitioners that want to help people, want to get people better, that's a hard conversation to have. So now, I know as a counter strainer now, like Larry was saying earlier, you check the anterior dysfunction, right? There's often neuromuscular dysfunction on the other side of the body, on the other side of the joint. It needs to be assessed and treated in order to help with that patient's somatic complaints. But what else, from you guys now, what does this technique do for patients? And you could, answer basing it on your own patient population or other that your students have worked with. But what does SCS do for our patients? We'll start with you, Ray.
Let me go ahead and jump in here, Kyle.
Oh, go ahead, Robert.
Yeah, what SCS does, especially with this full body scan, is it allows you to find the greatest restriction. It makes especially for like a new grad, I have a bunch of new grad therapists right now, over the last couple of years actually working with me. And what it does is it allows you to take all that knowledge that you learned in school, all that great science, everything that you learned in school, but it allows you to do something quick, do the full body scan from cranial to toes, quick, 3 to 5 minutes once you know where all the points are. Do that scan and start at the area that's the worst. It improves your efficiency astronomically because you're not doing all the things you know to do in the wrong place. You're doing the things you know to do in the right place. And I think that's been the biggest thing that I've taken away recently from working with my new grads is the efficiency that the full body scan provides to the therapist and to the patient.
Absolutely. Go ahead, Randy.
My practice is almost solely chronic pain. I see people that have been in pain 5 years, 10 years, 20 years. What counterstrain does for that patient, because it's such a perfect technique for chronic pain, because counterstrainers look where other clinicians don't look for dysfunction. And I do find that a lot of chronic pain is caused because no one has ever addressed the correct area of dysfunction on these patients. Now, counterstrain works quickly, even on chronic pain that's been around for decades. Okay, it works quickly if you treat the right dysfunctions. And so when I take someone who's been in pain for that long, and I treat them once and they stand up and they notice the difference. They can feel the change. They already can feel better in 1 or 2 treatments. It gives them hope. It's a tremendous hope giver for people that have been in pain for so many years and think that nothing can help them. Once you start knocking out these dysfunctions, they start to believe that maybe something can finally help me. And I've seen that so many times with my chronic pain patients.
Well, Randy, he just took the fire out of my answer. Patient comes to us and they've had PT, they've had chiropractic, they've had massage, et cetera, et cetera, et cetera. Sometimes I'll tell a patient, well, I'm going to do something totally different. I'm going to find where your dysfunctions are. I'm going to get rid of those dysfunctions and we're going to show some positive gains here. And when it happens, they just feel a sense of relief, feel a sense of hope that there is something out there that they can do something with. I get so frustrated when they've been to another practitioner 3 times a week for 6 weeks and they're no better. My question is, why do you keep doing that? Why are you going 18 times and you're no better? How about if you give me 3 visits and we'll see if we can make you better? And so this can be you're going to get a rapid response even on Monday after you take the course and been through the pre-training and all with the videos and all. You will make a difference on Monday. This course gives you, you're going to spend 80-90% of your time practicing techniques you're going to use versus the last 15 minutes of a 3-day course on things you're going to use. If you dedicate yourself to that and the scan, there's no way you're not going to be successful. And I have to say, through Randy's work and time, the instruction now is 500 times better than it was when I started, when I went to my first class. I mean, you will get it and you will be able to do it soon after you take the class. You just need to reverse your memory and commit.
Yeah, and I'll third that too. I think one of the biggest things that SCS does for my patient population, which is mostly chronic pain and chronically ill as well, is it initially at visit 1, it provides hope because they've had PT, they've had massage, they've had chiropractic, they've had acupuncture, and they're still in pain. Telling them, hey, I'm going to do something different. And then within 2 minutes, you're turning off the sharpest tender point they have in their body. They can tell that you're about to do something different for that next hour or 30 minutes or 45 minutes, however long your visits are. And they immediately start to believe that they can get better again, right? And you guys know from practicing, if you practice a long time or a short time, if the patient doesn't believe they're going to get better, they're not going to get better, no matter what you do. But counterstrain does. It provides that hope because it's different and because you can immediately turn off a tender point, which opens up a whole new world of possibilities for that patient. I do want to talk just quickly about the SCS Complete Body, and I see that we're getting some questions in the Q&A here for that. So what we've done as a new distribution model here, combined SCS upper quarter and SCS lower quarter into SCS Complete Body. There are over 8 hours online lecture and technique demonstration that you'll have access to immediately after you register for the course. And then required with that online content is attendance at one of our intensive 3-day labs. A lot of techniques in the video content. Our goal with the 3-day labs is not to review every single technique, but it's really to teach you how to, right? So the goal with the lab, teach you how to develop the skills and then really to help you develop the skills necessary to be able to do the techniques consistently, no matter what technique it is on the body. So we spend the first 2 days, day and a half to 2 days, really focusing on development, the differentiation between aberrant tissue tension, normal tension, what dysfunctional tissue feels like on bone versus muscle versus tendon, and then what a release feels like, and how can we get a release consistently. And then we spend our last day to day and a half on clinical application. So not review of every single technique, definitely practice the techniques, but all putting the pieces of the puzzle together to somatic complaints of your lab partner. Really is a course that we're really excited about offering, and there's never been a course that we've offered quite like this that I think is going to make people not only just teach them the techniques, but really a high-level manual there with high-level palpation skills. So just as a reminder, that is SCS Body that we're doing this year. In San Diego on June 18th, we have a lot left of that course. And then we'll also be in Spokane, July 23rd through 25th. In Chicago, September 10th through 12th. And then in Seattle on October 1st through the 3rd. Through the end of this month is a $50 discount with the coupon code SCS at checkout. So let me go through your questions here. Let's see if we have any clinical. I see a lot of more administrative types. I will be sure to answer these in the chat before I log off. But let me see if we have any clinical questions for the panelists here. I have a question from part of the JSCCI courses. So the legacy program or the mentorship program is going to be something separate from that. That part of our curriculum track that you take after cranial. So just to touch on curriculum track, we have SCS Complete Body, and then SCS Cranial for the cranial techniques. And then you can go one of two routes. We can go to certification. Okay, so I saw another question about certification. So it's SCS Complete Body and SCS Cranial is our prerequisites to test for certification, plus about 6 months of clinical practice. And then if you're not ready for certification, if you think your skills are up to par yet, then we do have mentorship opportunities, which will open for registration towards the end of the year for 2022. Let's see. I think that looks like all the questions that I currently have right now, and we're coming up, so that's almost perfect timing. Like I said, I will spend some time here going through the admissions because I didn't see any that would maybe relevant for the entire group. But thank you, Larry, thank you, Randy, and thank you, Robert, for spending this hour with us. Really appreciate your time. Thank you to everyone who attended and is watching on Facebook. Your time. Hope you guys learned something, and really look forward to seeing you guys in one of our courses this year.
Thank you.
Thank you.